Hello everyone, welcome to JFK University Medical Center Health Spotlight. I'm your host, Dr. Kishore Ratkalkar, pulmonary internal medicine physician, JFK University Medical Center, Hackensack Medical Group. As in our previous episodes, we covered many topics which are relevant to you, including cardiology, pulmonary, and all other related subjects. Today, we have an important topic, which is about brain injury, concussion, cognitive deficits, which affect each one of us as we get older, and dementia. To discuss all this, it's my honor and privilege to introduce you Dr. Christine Greiss. She is the medical director of concussion program. She is medical director for Center of Brain Injuries at JFK University Medical Center, Hackensack Meridian Hospital System. In addition, she is a clinical associate professor at Robert Wood Johnson Medical School and Hackensack School of Medicine. Dr. Greiss, concussion, which is a real common phenomenon. Every parent will hear it. The kids are getting injured. They have a concussion. You see these athletes who get injured, especially those who are in sports, like football, etc. So could you explain to our viewers what concussion is and how we diagnose it, and what are the implications of an injury of that sort?
Thank you for having me, Dr. Ratkalkar. It's really a pleasure to be here with everybody, and I'd like to start off by saying it's really an honor to be here, and I really enjoy talking about this topic. It's very dear to my heart. In a concussion, we generally think of it as a hit to the head. Some people used to believe that a person, there's no way they would have had a concussion if they didn't get hit directly on their head. That is not the case. We know now that simple jolts and force vectors transmitted through the body, if a person is catapulted through the air or their body shifts in such an aggressive motion, causing a whiplash in their neck, those forces can go through the brain and really be enough to cause a concussion. So what really happens is the brain is really nice and free-floating inside this encapsulated skull, and when the brain shakes inside the skull and rattles a little bit, we tend to see that there's a chemical fluctuation. This chemical change actually causes a delay in the signals that are moving throughout the brain. And so this delay in signal manifests as a change in a person's day-to-day activity, their ability to function. So that being said, a concussion is actually not a structural injury, it's a functional injury. Okay. And the way that we diagnose it is not through CAT scans and MRIs. Sometimes
mostly clinical?
Absolutely. We see sometimes patients will go to the emergency room, they get a CAT scan, it's read as unremarkable, they're sent home and said, well, you may have had a concussion, we're not really sure. Just go home and rest. We see also, well, we'll get an MRI just to see if we've had a concussion. There's no way we can actually diagnose a concussion just through MRI.
I see.
That's like saying diagnosing a nerve injury through an X-ray. Sure. It just doesn't happen that way because it's not a structural problem. The way that we like to diagnose concussions is actually putting the brain to a test. And how do we test it? We test it in different series.
Okay.
We test the visual system.
Okay.
We test the ability to maintain balance.
Okay.
We test the hearing.
Okay.
We test something called the speed of the visual and balance system together.
Okay.
Called the visual and vestibular ocular muscles and the vestibular ocular reflex.
Okay.
So we test all of these fine-tuned neurological tests, not just a basic strength test, because we need to test it based on where we will find the problem.
How long do you watch a person who has this injury and you suspect that the patient had concussion?
We monitor the actual test itself. Takes up to an hour.
Okay.
The way that we diagnose the concussion is if they have failed All of these categories.
Okay.
Their ability to maintain the vision.
Okay.
Their balance has been affected.
Right. Okay.
Their ability to maintain processing information quickly as their baseline.
Okay.
We test, they are their own neutral baseline. We test also their ability to maintain emotional regulation.
Okay.
All of those we watch for usually a matter of 2 to 3 weeks.
Okay.
And we monitor and see, did they truly have a concussion based on all of these symptoms put together?
Correct.
And if they do check off those boxes, then we know that most likely than not, they have suffered a concussion.
Right. So when we say that they have suffered a concussion at that point, your MRIs are negative, your CAT scans have not shown anything, and this is a clinical evaluation that you have done. So what is the protocol afterwards to see their improvement and where they go and how you treat them?
Well, we then do an autonomic test, which is more objective.
Okay.
Autonomic testing actually entails changes in blood pressure from the laying down position to the standing up position.
Sure.
We also check their blood pressure after we do a vestibular ocular reflex. Have them walk, and we see that
So
even...
if you can just expand on that,
Sure.
vestibular ocular, so our viewers can understand that a little bit.
Sure. It's pretty much we have the patient move their eyes right and left, and we have them walk down a hallway somewhere about 200, 300 feet and back, and then we have them lay down flat, and then we also move their eyes again left and right, which is form of a saccades testing.
Okay.
Their inability to do so is actually one of those risks, simply because it's easier to move up and down than
Sure.
left to right. That's why
Sure.
social media is up and down, shopping is up and down,
Right.
But reading is harder
Right.
and cannot be maintained as long.
Okay. And what is the prognosis of these patients?
That's great question. That's $1 million question. We usually see that a lot of patients, if it's their first injury, they tend to do better. But just like any other aspect in the body, let's say it was the knee joint and it was injured multiple times,
Right.
the chances of it recovering
Right.
are much less, back to normal.
Okay.
And so the same goes for the brain. Chances of recovery depend on whether or not they had a previous injury and when they had it. That's going to be important in CTE.
I see.
So if they had another concussion when they're 14 and now they're 35, chances of them recovering are pretty good.
Okay.
But if they had one a week ago or 2 weeks ago, and then they lose their balance because of the first one,
Right.
they fall and hit their head again, well, the chances are
Multiple.
worse and worse. Exactly.
Multiple is a problem.
Yes, multiple is a problem, as well as multiple within a short time frame.
Thank you. We're going to take a short break and we'll return after a short break. Thank you for watching. Welcome back. Your host, Dr. Kishore Ratkalkar, here with Dr. Christine Greiss, discussing concussion, brain injuries, and in the last segment we just discussed concussion, and now we'll move on to a much serious problem, which is traumatic brain injuries. And traumatic brain injuries again are moderate and severe, but I'll let our expert here, Dr. Greiss, explain to us what happens in traumatic brain injuries and what we can do to help ourselves through this process. Thank you, Dr. Greiss.
Thank you, Dr. Ratkalkar. And so, in discussing traumatic brain injury, we always look at the mechanism first. Generally, with traumatic brain injury, the sense of the definition is that there was something present on imaging. There was some structural deficit in the brain itself.
Unlike concussion.
Unlike concussion, which it won't appear on a
Sure.
typical conventional MRI report of the brain.
Sure.
When it comes to moderate or severe brain injuries, as being a structural problem that we could see on the image, we tend to see natural bleeds of the brain in different aspects of the brain, different layers, because the brain has many layers. And based on where the bleeding happened, can really affect prognosis.
Okay.
So for instance, if a person falls on the side of their head, we can have somebody standing and having fun on a table and then they lose their balance, they fall to the side, they may sustain an epidural hematoma.
Okay.
That's different because if they survive it and it's outside the brain tissue and they survive the first 24, 48 hours, their prognosis is excellent.
Okay.
They do pretty well. We see them in the clinic. Sometimes the trainees are surprised that they're able to go back to driving and working within a matter of a month and a half.
That's wonderful.
Which is amazing. But then we see some of the bleeds that are actually embedded under that inner wall of the skull and under the dura. And so we see sometimes the subdural, what we call them subdural hemorrhages. They don't tend to resolve as well. They take longer because the brain has to put in more work to absorb all of that blood and all the fluid and then normalize the pressures.
True.
So that takes a little bit longer time. We also see the bleeds that are subarachnoid hemorrhages. They tend to come with their own basket of problems. So if you think about, for instance, dropping your phone in the water, the whole electrical system won't work very well. And so you always think about these subarachnoid hemorrhages because the arachnoid villi actually transmit CSF into the brain.
Right.
And when it happens, they're prone to seizures after the injury. They're the ones that are prone to hydrocephalus, other complications.
The swelling of the brain.
And the swelling itself.
Right.
So there's a lot of issues with the brain itself in terms of manifesting, and dealing with all of that edema or swelling. When it comes to the severe brain injuries, there may be nothing on MRI except the speckled snowstorm, what we call appearance on the image. It's called diffuse axonal injury. That's in high-speed motor vehicle and motorcycle crashes. We see those are the patients that we call in a coma. Mm-hmm. Some are in a vegetative state, which is different from a coma because that's a presence or absence of them sleeping and waking up. Right. And then there's the minimally conscious. Those are very different because all the wire is doing is it was stretched. So think about, for instance, a phone charger. We all have those chargers that if we tug at them long enough, then we plug in our phone, it won't work.
Correct.
Because the outer lining, which is the nerve has a nice coating around it, that outer coating is stretched, it's pulled, and that membrane is damaged. And that happens across the entire system, the central operating system, the brain, and therefore the patient is not conscious. They're not awake. So we also manage those patients.
That's what you call vegetative state.
Yes. I also am proud to be working at JFK where we developed early in the 2000s the JFK coma recovery scale.
Okay.
Until this day, we are implementing it after their work, and it's known nationally as the ability to track a patient as they're emerging from a coma. That's and they're regaining their consciousness.
That's wonderful.
So sometimes we try to get the patients to give them stimulants, sleep medications, to kind of help them regain awareness of their surroundings and memory of everything that happened.
Okay, great. You have a very good brain injury trauma unit. Can you share with our viewers the unit that we have at JRI, at JFK University Medical Center?
It's my pleasure. I work with a wonderful team. It's really the team approach. We have, besides the physicians, we have the brain injury fellow, we have resident physicians, but then all of our staffings, we have brain injury certified nurses, and they are very familiar with what brain injury complications look like. Okay. They manage complex patients. And when it comes to also neuropsychologists, we have a neuropsychologist every day doing this
that's-
coma recovery scale
Wow.
with our patients, which is wonderful.
And then the families are involved in
The
that.
families have to be involved. We call them
Right.
care companions.
Right.
Because sometimes it's great to see or hear, as a person is under this vegetative state, to hear a loved one, a familiar sound.
That is awesome.
So that is wonderful. We have a team of physical, occupational, speech therapists, and recreational therapists. So they're getting 3 + 4 hours of therapy a day, 5 to 6 days a week, just working on emerging and recovering from, this trauma. So besides that, we also have a great team of all of the aides, and we have a great team of social workers, because they are equipped in all the resources available to help their patients and their families regain the ability to care for their loved one. This is the most life-changing event for families.
Absolutely.
So we always try to see all the resources possible in the community to help these patients return home. And the nice thing is we also have them follow up with the physicians
Right.
in the outpatient basis until they're stable.
So usually, you have intensive care unit, and then you have the brain trauma unit. So patients who are moderate or severe traumatic brain injuries, first when they are stabilized in intensive care, you bring them over to your unit.
Yes, correct.
And because of what you have there, the outcomes are much better for patients with brain trauma injury. And that's why JRI is one of the nationally recognized centers for excellence, not only in New Jersey, but only nationally, as I said. It's one of the top programs. And because of clinicians like you, you make a difference in patients who have traumatic brain injuries. And we thank you for that. We're
Thank
going to
you.
take a short break, and we'll return after this break. Thank you so much. Welcome back. I'm here with our expert, Dr. Christine Greiss, specialist in traumatic brain injuries at JRI, JFKUMC Medical Center. Dr. Greiss, welcome back. We discussed concussion, we talked about TBI, traumatic brain injuries, and now the most important segment, which affects most of us, especially elderly people like me, the cognitive age-related decline, the risk factors, dementia, CTE, and other related matters as we get older.
Thank you. This is a topic that's also near and dear to my heart. I always like to continue to discuss with people, with all of my patients, in terms of how we can improve and allow them to really live healthier and better lives. One thing that I will mention is we'll talk about CTE, and then, because it won't affect as many patients as cognitive dementia and the rest, but people understand CTE as a disease of many repetitive head injuries. And what I'm here to always say and clarify is that CTE is a diagnosis that can only be made post-mortem, so after death. However, we have a saying of CTE syndrome. And it
Can
really...
you just elaborate what CTE is to the...
Yes, so CTE is what we call chronic traumatic encephalopathy, and it is a neurological disease, or what we call neurodegenerative disease, where the brain at a very young age, young being anywhere between 50 and above, starts really declining cognitively, and emotional regulation starts being affected. We see a lot of patients that lose their memory, lose their ability to control behavior, and lose their ability to be able to even live with any of their loved ones in a normal community setting, and they need to isolate constantly. This disease occurs because a simple protein is deposited, and it's not a protein we want deposited in the brain, and that causes strangulation of blood supply, and it fluctuates. So that being said, we tend to see these manifestations in those who have played contact sports for many years, those who have sustained repetitive head trauma, so constantly getting hit in a very short period of time. So usually in contact sports, the person is at risk for getting an impact every 40 minutes during the game. And so it doesn't happen in a person who's had maybe 3 concussions over 10 years. That we don't tend to see it.
Okay.
So that's that. As for cognitive impairment, now moving on to really the million-dollar question is risk factors. It's still really the same when it comes to managing health, obesity, poor lifestyle habits and not healthy lifestyle habits,
drinking,
alcoholism, drug use, any of the toxins that we put into our bodies can affect our ability for our nerve to function.
Sure.
What we do see in this day and age, because cognitive function is a very almost like the attractive strength of this day and age, because we're no longer cavemen. So we can't really show off our biceps or our lift and say, oh, we're able to move and lift this. That used to be a portrait of strength and health back in the day, not anymore. Sure. So how do we maintain that? Usually the best way is to improve and almost train our brains to do what technology is doing for us. It's almost also to allow our brains to expand in many ways in terms of thinking, decision making. Sometimes they say, in a simple game of chess for an hour, you can burn up to 150 to 200 calories.
That's right.
Why? Because cognition does burn energy too.
Correct.
We know very well that constantly training our brain for spatial awareness, not always relying on maps and navigation systems.
GPS,
Exactly. Those are the things that allow our brain to train and become better and expand more. And the likelihood of getting cognitive impairment as we age are much less. That's why there's no wonder that, people like you, Dr. Ratkalkar, are going to, it's an impressive thing because high level of education is protective against cognitive delay.
So you can still do executive
decision
making
yes.
while you're doing this. So as you said, music is another thing that is
yes.
very, very helpful to keep this going, and any other things.
Yes, music, handedness, and so dexterity. Some there's nice studies that show that even simple things as knitting, fine motor regulation has been shown to help with the deepest aspect of the brain. That means you're allowing circulation to happen in the primitive brain itself, and that blood supply is regenerating and also regulating sleep.
So cognitive decline is not dementia per se.
Correct.
And dementia and Alzheimer's, they're a different category.
Yes, dementia and Alzheimer's. Dementia has many different forms. There's a Parkinson's dementia. There's dementia just from other unknown causes, encephalopathic dementia. There's also vascular dementia.
Correct, which is more common.
Which we see as more common, correct. Those are certain genes that get turned on because of our environment that we allowed to happen. So, and that happens also with lack of deep sleep, which again, high states of anxiety affect deep sleep. And when one person doesn't go into that deep sleep and get at least 3 REM stages a night, then the chances of them retaining short-term memory are less.
Right, so that is somebody with obstructive sleep apnea who is not really treated.
Correct.
You will get all these things.
Absolutely.
So one of the examples of that.
Yes.
And Alzheimer's is a topic by itself. And if you can just share a couple of seconds or a couple of minutes on that.
So with Alzheimer's, we do get a gradual decline in cognitive function. Again, there are certain genes that turn on in the brain that this happens. It affects more the short-term memory first and the ritualistic behavior first. So it almost creeps up on people. What we see is a lot of that, problems, as families are the ones that tend to complain that they're not noticing their loved one.
So really, thank you, Dr. Greiss, and I must say that this has been a very informative episode. Uh, Traumatic brain injuries are real, and the concussion is real, cognitive issues and dementia and Alzheimer's dementia, they're all there. I recommend that anybody who has any questions or want to take help, go to our JRI brain trauma unit and the expertise of Dr. Greiss. It's a privilege to have you here today, and I hope you enjoyed this show. If you have any questions, please email us. We'll be happy to answer you during your next episode. Thank you so much.